Well, very good morning to all of you, and good afternoon and good evening to all others who are joining from rest part of the world. Today, our guest speaker for the day is no other than Dr. Rita Nair, ma'am, from Kolkata, and she's going to lecture us on clinically relevant classifications of lymphomas. This webinar is brought to you by Mumbai Hematology Group, supported by Roche, Unipath, Lucien, and Nirvid Life Sciences, and very well managed by Perfect Square. I thank Team Roche, Unipath, Lucien, and Nirvid, Mr. Yash, Mr. Kalpesh, and the team from Perfect Square, Executive Committee of Mumbai Hematology Group. Our chief guest for the day, Dr. Devdutt Basu from Pondicherry. Our guest speaker for the day, Dr. Reena Nair from Kolkata. All our discussants were themselves very eminent hematologists, hemato-oncologists, as well as hematopathologists. And you participants for sparing your Sunday morning, afternoon, or evening from whichever part of the world you have logged in. Let me give a flavor of our next weekend activities. Next Saturday, that is 5th of July 2025, we have got two lectures. First lecture is at 5:45 p.m. Indian Standard Time on optimizing myelofibrosis management, early treatment with ruxolitinib by Dr. Alok Shetty from Tata Memorial Hospital, Mumbai. And followed by, we have got another lecture that is on 7 p.m. Indian Standard Time and 8:30 a.m. Central Time USA on targeting anemia in myelodysplastic syndromes and myelofibrosis by Dr. Nazima Gangat from USA. And the following day, that is Sunday, 6th of July 2025 from 11:30 a.m. Indian Standard Time and 7 a.m. UK time, we have Dr. Sridhar Chaganti from UK speaking to us on update on DLBCL from EHA and Lugano. Let me introduce our discussions for the day, and they are displayed here in alphabetical order. I will pause for a while for you to have a look on all our discussions for the day. These are very eminent hematologists, hemato-oncologists, as well as hematopathologists all over the country. So these are our discussions for the day. Now it's a time to introduce our guest speaker for the day. We have no other than Dr. Reena Nair, ma'am, from Kolkata. Dr. Reena Nair is Senior Consultant, Clinical Hematology, Head, Department of Medical Oncology at Tata Medical Center, Kolkata. She did MBBS and MD Internal Medicine from Goa Medical College under Bombay University in 1979 to 1988, followed by residency from 1988 to 89, and then followed by fellowship 1991-1994 in medical oncology at Tata Memorial Hospital, Mumbai. She is then the faculty from lecturer to professor, Department of Medical Oncology at Tata Memorial Hospital from the period 1994 to 2012. She is also the principal investigator in 35 clinical trials. These are investigator-initiated as well as industry-sponsored clinical trials. She is also the executive committee member and faculty at Australia and Asia-Pacific Clinical Oncology Research Department, that is ACORD workshop from the year 2010 to 2018. She is also the international scientific advisor to the Lancet Hematology from the year 2020 to 2022. She is also the guest editor of Lymphoma Outcomes from India from Frontiers in Oncology from the year 2021 to 2022. She is also the editor, Management of Hematological Malignancies in the LICS from Frontiers in Oncology from the year 2022 to 2023. She has published over 125 papers and 15 book chapters. Her current interest is management of hematological malignancies with special interest in lymphomas. She is also the founding member of the National Myeloma Group, that is IMAGE, from 2017 till date. She is the principal investigator of the OncoCollect Lymphoma Registry from 2018 till date. She is also the founding member of the Immuno-Oncology Society of India from 2019 till date. She is also the founding member of the Women for Oncology India Forum from 2021 till date. Her recent awards and honors include Inspiring Oncologist 2020 on Doctors' Day Conclave, Economic Times, Aprajita Saluting Womanhood 2021 10th Annual Awards, Indian Society of Medical and Pediatric Oncology Oration 2022. And today she is with us and she is going to lecture us on clinically relevant classifications of lymphomas. But before she does that, let me introduce our special guest and chief guest for the day, no other than Professor Dr. Devdutt Basu from Pondicherry. Just to introduce Devdutt Basu sir, doesn't require any introduction, but it's my formal duty to introduce Professor Dr. Devdutt Basu. He is a professor of pathology at Mahatma Gandhi Medical College and Research Institute, Pondicherry. He did his MBBS way back in 1985 from Maulana Azad Medical College, Delhi, followed by MD Pathology in the year 1990 from Maulana Azad Medical College, Delhi. He is also the former professor and head of pathology at Jipar, Pondicherry. He is a fellow of Indian College of Hematology and has about 239 publications. His interest in hematopathology and medical education. Today he is with us and I welcome him to inaugurate our webinar and give some words of wisdom. Over to you, Dr. Devdutt Basu, sir.
Good morning, everyone. And it's indeed a privilege, Dr. Amit, and especially Dr. M.B. Agarwal, for giving me this honor of inaugurating. I really do not know whether I deserve to be a chief guest at such an august audience, but since I have to say something, I think I will discuss a little bit, not long, about my path on a less traveled path, my journey on a less traveled path, the path that I took, and that is getting into pathology and then getting into hematopathology and remaining in academics. As you said, I did my MBBS way back in 1985, and that was the time when I joined soon the Department of Pathology at Maulana Azad Medical College. And that was my foundation of the training that I got. I came in close contact with teachers who were exceptional leaders in their field. And what was interesting for us at that point of time is though none of my teachers had these super specialization degrees, they were all carving their own niche in specialization. We had hematopathologists of the cadre of the immense cadre of Dr. Tejinder Singh, Dr. Shashi Prakash, Dr. Sudharani, Dr. Shom. On the other hand, there was histopathology, which was being managed by 4 or 5, Dr. Uma, Dr. Chauhan, Dr. Mandal. There was cytopathology being managed by Dr. Geeta Jairam. So we got the feeling that we are getting trained under real specialists, and that's something I would encourage all of you, all of our teachers and all of the students to try and carve an area of interest and work in that. That helps in development of that specialty in the department, as well as your own path is better created. So it's good to be focused in one area, rather than saying that I would like to do this on this and that and that. So that was one thing that I learned, that I got groomed into. Secondly, another feeling that I had when I was doing my PhD, all of us this dilemma, we have left a clinical branch. How is it to be in pathology? That myth was soon diminished immediately. We realized that pathology is a very clinical a branch. I mean, our exposure to patients during FNACs, during bone marrows, during just general contact with patients, it was good. So another urge that what I learned there was to treat that request form as a patient. Believe that you are doing patient care. That is our contribution. We do make an impact, no matter if we are diagnosing acute appendicitis or a lipoma or a normocytic normochromic anemia. We are making a difference in the patient's history. Another thing about pathology, especially hematopathology, which interested me was it was a tech savvy. We talk of AI and machine learning now, but automation was there many, many years ago. Machines were telling us there is microcytic hypochromic RBCs, there is agglutination. So pathology has been in the forefront of technological advancement. So that's another way to enjoy pathology. Philadelphia chromosome discovered in 1960 by a pathologist, and that was written as the first page in the first chapter of what is now known as personalized medicine. So it's a good branch to be there in it. Another little thing which is a prelude to today's talk by Dr. Arina Nair on lymphomas is my entry into lymph node pathology. And for that, I thank Dr. Kikeri Naresh and the National Lymphoma Registry that was built way back in the early 2000s. And that is how I got into. And there is a little plea and a little request that let hematologists handle lymph nodes. Hematologists understand the nuances of these blood cells better than I think any of it. So that's another privilege that I've had of doing lymph node pathology all my years, and therefore I've been able to link it to hematology and pathology. It's really a mixture of good things about both liquid hematology and the solid hematology. With these few words, I don't think I should stand in the way of what is actually today's presentation by Dr. Veena Nair. I wish all of you the very best in whichever field you do, and hematology, hematopathology is a good branch to be. So those of you who are juniors, who are still deciding, look it up as a career choice of yours. Thank you very much, and it's been an honor to be present here. Over to you, Dr. Reena, I think.
Thank you, Dr. Basu sir, for your wonderful and kind words. I think that were most inspiring words you already spoken, sir. Fantastic words, beautiful words, and very inspiration to all our future budding hematologists as well as hematopathologists. Thank you, sir. Thanks for
Thank
being
you.
as our chief guest for the day. And now, ma'am, screen is yours. Please go ahead.
So thank you very much, Dr. Basu. And of course, Amit, for always hosting the Sunday morning meetings. My only disclaimer today is that I am not a pathologist. And so at the end of my talk, I will take all the help from Dr. Basu to actually answer many questions. Can you see my slides?
Yes, ma'am. Please go ahead.
Okay. So today we'll discuss clinical relevant classification of lymphoma. It is a clinician's perspective purely, and one may wonder that we already know it is Hodgkin's and non-Hodgkin's, and then why bother us, especially the clinicians, with more classifications. Just a word about classification. It is fundamental for evidence-based treatment of individual patients, for monitoring of global disease burden, investigating all aspects of disease causation, prevention, and therapy. And the WHO classification of lymphoid tumors provides a global reference for diagnosis of lymphoid neoplasms for a long time, since its third edition in 2001. It was based on the real classification, that is the revised European American Lymphoma classification of the International Lymphoma Study Group, which was in the early 1990s. Putting it very simplistically, we have believed for a long time that each type of lymphoma results from a lymphocyte which has been arrested at a stage of development and then transformed into a malignant cell. If we look at the classifications, they have been changing for the last 60 years. The first, so to say, scientific classification of lymphomas dates back to 1966, which was the Rappaport's. And I will use a little bit of the past to explain how we have reached what we do in 2025. We had lots of people in Europe and US working on various immunohistochemistries, and they came up with various classifications over the years, till finally we saw what was a clinically relevant working formulation in 1982. That was the basis of the real classification after we came to know what immunohistochemistry taught us. And thereon, the WHO seems to have taken over on the backbone of the real classification. And the most recent edition has come out in 2022. And the book is now available since last year. The world is full of politics. So almost at the same time, we have the international consensus classification. And with a few differences, I think both the WHO and the ICC say more or less the same thing. So if we go back 60 years, it was very simple. We had only the microscope. If you looked at the pathology and it was nodular, which was later called as follicular, it was termed as a follicular lymphoma. And if the involvement of the lymph node was diffuse, it was called a diffuse lymphoma. We had two types of cells, the small cells and the large cells. And depending on whether it was nodular and small cell lymphoma, it was termed as indolent. And if it was large cell and diffuse, it was termed as aggressive. Over time, what happened was there were permutations and combinations of this, and then the working formulation came up, which told us that low-grade lymphomas were those which had follicular architecture and small or mixed cells, and the intermediate grade lymphomas were those which had large cells. But then people noticed that there were immunoblastic cells, there were lymphoblastic cells, and then there was the Burkitt's a very blastic lymphoma, which actually did not fit into the low grade and the intermediate. And so we knew that another group of lymphomas was arising. At around the same time, the US and Europe was very much involved in actually looking at what these lymphocytes expressed. And all of us know that they differentiated the lymphomas as B and T cell lymphomas. And uh, actually started out the development or this antigen expression according to the stage of development of T cells, which is now quite uh, well known and molecular work is on in this area. But since T cell lymphomas are less than 15%, this work has taken a longer period of time. And we know that the B cell antigen expression and development of stage has been much better developed over the last few years, since about 85% of the lymphomas are B cells. And you can categorize these lymphomas as those that arise from the bone marrow, those that are mature lymphomas, which arise from the lymph node, and eventually the lymphocytes will go into the peripheral blood circulation and create lymphomas or plasma cell dyscrasias. And the antigen expression, to a large extent, with very little overlap, gives us a fairly easy way to diagnose these lymphomas. So looking at the normal B cell differentiation and its relationship to the major B cell neoplasms in this slide, in the marrow, if there is a lymphoma that develops, which means maturation arrest in the lymphoblast, we get lymphoblastic leukemia or lymphoma. Then these knife cells enter the lymph nodes. If the development of the lymphoma is in the mantle cell, mantle zone, it is called the mantle cell lymphoma. As they enter the center or the germinal centers, depending on where the arrest is in the centrocyte or the centroblast, we get the most common lymphomas that we are used to treating. And eventually, if the lymphocyte arrests in the marginal zone or in the peripheral blood, then we get the low-grade lymphomas or the plasma cell dyscrasias, with the exception of some DLBCL. So now the backbone of the classification in 1994 changed from just low-grade and high-grade, small cell and large cell, to T cell or B cell lymphomas. And even at that time, we did not know where Hodgkin's arose from, but we knew it's a lymphoma, and so it is put into the classification. And the two types were classified as precursor or mature B cell neoplasms or T cell neoplasms. The B cell neoplasms are those which are commonly seen in our practice almost on a daily or a routine basis. The T cell lymphomas are much less common. And for ease of understanding T cell lymphomas, we can easily categorize them as leukemic lymphomas, extranodal lymphomas, cutaneous lymphomas, and the regular nodal involvement in lymphomas. The immunohistochemistry definitely helps us to identify the subsets of the mature B cell and the mature T cell lymphomas, and also helps us to distinguish the classical Hodgkin's lymphoma from the NLPHL, which we now know at the turn of this century that it is a B cell neoplasm. The CD25 and 23 positive B cell lymphomas are CLL, SLL. If it is 23 negative and cyclin D1, it is mantle cell lymphoma. The CD10 BCL2 positive lymphomas are follicular lymphomas if they have a nodular pattern. And if it is a diffuse pattern and it is CD10 positive and BCL2 negative, we know we are trending towards a Burkitt's lymphoma. So the classification of the mature B cell lymphomas has become very clear now. Similar work is on and has been done for T cell lymphomas, and as I mentioned, for Hodgkin's lymphoma also. Dr. Basu mentioned that Philadelphia was one of the first chromosomes or translocations to be detected. In lymphomas too, we have known for a long time that if it is 1814, it is Burkitt's. If it is 1418, it is follicular. And if it is 1114, it is mantle cell. And over time, many more translocations have been isolated. As molecular work happened, we began to understand what happens with each of these translocations and what are the oncogenes which are expressed, which actually are causative in the formation or in the development of these lymphomas. So there was a realization that the real classification on morphology and on immunohistochemistry will not serve the purpose because there was sub-classification of many of these lymphomas on a genetic and a molecular basis. And this also had to be imbibed into the classification system. And that's when the WHO started working on the classification, which would be uniform across the world. So now if we look what happened post the real classification with quite a lot of cytogenetics and initial molecular work, we realized that all B cell lymphomas were not diffuse large B cell lymphomas. There was something known as cell of origin, and there was something known as high grade lymphomas, which on the basis of FISH were classified as double hit, triple hit, or just as high-grade B-cell lymphomas (NOS). So here began the classification of the original real classification. The T-cell lymphomas more or less continue to be the same, but we have begun to identify more subgroups of T-cell lymphomas as well. We know the Hodgkin's lymphomas continue to be NLPHL and classical Hodgkin's lymphoma. And there has been some attempt to put the post-transplant lymphoproliferative disorders in a group. And the histiocytic and the dendritic cell neoplasms also have become a part of the lymphoid classification. So over the past, what has happened is the microscopy showed us how to differentiate Hodgkin's from non-Hodgkin's. It also showed us how to differentiate low grade from high grade. The IHC showed us how to differentiate T cells from B cells and actually helped us to initiate treatments which were now targeted. The B cell lymphomas received rituximab, and more recently anti-CD30 has become an upfront treatment for Hodgkin's lymphoma also. We realized that by treating these patients on protocol, there were some patients who were doing reasonably badly. And that is when we realized that at a cytogenetic level or a FISH level, all DLBCLs were not just DLBCLs, but some of them were high-grade BCL lymphomas with MYC translocation with or without BCL2 and BCL6 translocations. And these in particular needed to be treated differently, otherwise they would relapse frequently and the patients would succumb. So this has been the past and the present. The most relevant classification today for us comes from the new WHO classification, which is the 5th edition. From one volume, it's become 2 volumes, and it is closely, and the ICC has been a close competitor at the international level. The WHO HEME 5 recognizes the increasing importance of genetic and molecular diagnostic tests and also understands that these are really not available universally. So while they still remain more morphological and immunohistochemistry with the more easily available genetic and molecular tests, we know that for minimal criteria of diagnosis, these essential criteria are now important because treatments are different for different lymphomas. But in future, we wish to get to the desirable criteria where each diagnosis will be refined not only to the category, the subtype, but even beyond that. And that is what the next part of my presentation will be on. So we have this system which has come up, which is actually an evolution of the prior classification. It allows continuity in daily practice and for the ongoing trial. It applies a hierarchical system. So we now not only look at the classification as per category, we look at the family class, the entity type, and also the subset. And this has actually happened because we have recognized increasingly the importance of the genetic and molecular data that has evolved in the last 25 years or so. Efforts to prevent overdiagnosis by recognizing clinico-pathological non-neoplastic entities which mimic lymphoma have been made for the first time in this classification. And there has been an update on proliferations associated with inborn errors of immunity and acquired immune disorders. So these are some of the key areas in which changes have happened. And I will definitely not go through the entire classification of the fifth edition, but I will show you where these changes have happened and how they are actually helping us to understand the disease much better. So it is now very correctly, as Dr. Basu said, technology on the forefront, clinicians following the technology. So if we look for the first time in the blue book, what has happened is there are entities which are actually benign proliferations, which were not previously included. And this includes the reactive B cell rich lymphoid proliferation that mimics a lymphoma, IG4 related diseases, the Castleman's diseases, and even in the T cell, the Kikuchi Fujimoto disease, there is an indolent T lymphoblastic proliferation and the ALPS. And we need to be aware of these because if we treat them with all our lymphoma patients, our results are going to be definitely better than what we would expect, but these patients would have been treated unnecessarily. So let's start with the low-grade B-cell lymphomas. For a long time, we have known that the highlights of this group are hairy cell leukemia, splenic marginal zone lymphoma, the red pulp disease, P prolymphocytic leukemia, and the CLL. The new classification has done away with prolymphocytic leukemia because as we look at the molecular and the genetic aspects, most of these are actually splenic B cell lymphomas or they are mantle cell lymphomas. And otherwise, they are just accelerated or prolymphocytic progression of CLL. So this is the only entity which has been deleted from the new classification. We always had a hairy cell variant, which is now known that it comes from the splenic B cell lymphoma leukemia with prominent nucleoli. And so this variant is no more a part of hairy cell leukemia. And hairy cell leukemia has become very clear with the BRAF being involved in these patients. So B cell prolymphocytic leukemia is an entity deleted. The maximum changes which have happened in the diffuse large B cell area, where we had already realized that there was a high-grade lymphoma. We would otherwise have a variant Burkitt lymphoma with an 11q translocation, which now is an entity of the high-grade B cell lymphoma and is no more included in Burkitt's lymphoma. And then there were the uh, earlier DLBCLs with chronic inflammation, the clinical subtypes such as the primary CNS lymphoma, the primary mediastinal B cell lymphoma, testicular lymphomas, and the vitreoretinal lymphomas, which were actually clinical and now have been clubbed together as an entity called the primary B cell lymphoma of the immune privileged sites. We also would have a large number of lymphomas, which we called as the gray zone lymphomas. Now it is only the DLBCL and the CHL, that is the intermediate between DLBCL and Hodgkin's lymphoma, which is the mediastinal gray zone lymphoma. The remaining have gone out of the gray zone entity and are either a part of the high grade lymphoma of the B cell origin or have been fitted into various subtypes of the large B cell lymphomas. So what has happened is we've moved from the B cell category also further and classified the diffuse large B cell lymphomas as DLBCL NOS and the other large B cell lymphomas. Note that the term diffuse has gone out from the WHO heme in the remaining lymphomas. The morphological subtypes we have known for a long time. What has happened with the technological evolution is understanding the cell of origin, which is the GCB and the non-GCB, And with the translocations and the FISH tests available, understanding the genetic subtypes, which were DLBCL, NOS, and the high-grade DLBCLs or the double hit DLBCLs, which had the MYC and the BCL2 rearrangements and definitely did much worse than all the other DLBCLs. The new entities in the other large B cell lymphomas is, as I mentioned, the atypical Burkitt's is actually a high-grade B cell lymphoma with 11q aberration. The mediastinal or the gray zone lymphomas are reduced to gray zone lymphoma of the mediastinum, which is a intermediary between DLBCL and Hodgkin's. And in times to come, as more work happens, I'm sure this will also have a definite separation from being in the middle part, middle area. We of course know that all high-grade B-cell lymphomas are not characterized by MYC and translocation of BCL2, and so there are still high-grade B-cell lymphomas which are termed as NOS. The chronic inflammation lymphomas are the fibrin-associated large B-cell lymphomas, and we have an entity now called the fluid overload associated LBCL. So look out for these new entities. We may not have found them earlier because we were not looking for them. Coming to cell of origin, about 25 years back, on gene expression profiling, the DLBCL NOS was separated into what looked like the germinal center B cell and the activated B cell. And the outcomes were really different for the patients who were GCB versus the ABC. And these results are for patients in the pre-rituximab era. In the rituximab era, also, we continued to see this difference between the GCB and the ABC subtype. And so cell of origin became a really important aspect of classifying DLBCL NOS and was also used as a means to actually plan treatment, especially in clinical trials of ABC being a worse outcome lymphoma. And so they tried many combinations of other drugs along with the standard treatment to improve the outcomes of ABC lymphomas, but we really did not see an impact of that, and I will tell you why. The others was because of the molecular and the genetic testing available, we could now understand that B cell lymphomas with MYC translocations did badly. And if they were associated with BCL2 rearrangements also, they were the double hit and definitely did not uh, have great outcomes with the standard CHOP-like therapies. And so what has happened to the DLBCLs from the previous edition to now is that we know that the DLBCL NOS numbers have come down because they have been recategorized in various other subcategories and the treatments are getting refined over the period of time. And so it is the advancements that are actually helping in understanding which patients need the standard treatment and which patients definitely need more treatment. We also know that all the DLBCLs which we were classifying as clinical, whether it was testes, mediastinal, CNS, now is included in the immune deficiency dysregulation associated lymphomas. And so we know that they can be treated in a similar way. And I will show you also what is the difference in their treatments as compared to the de novo or the DLBCL NOS. For some time, we have known that the high-grade lymphomas need more aggressive therapies, and most of us have been treating them with dose-adjusted EPOC or hyper-CVAD or some such therapies in order to get more patients into response and cure. So the last 20 years, technology changed, but the management of patients remained our CHOP after the change or the improvement in outcomes over CHOP. And despite what we did, improving the anti-CD20 monoclonal antibody, addition of a large number of targeted drugs along with the standard backbone chemotherapy, whether it was lenalidomide, bortezomib, ibrutinib, or bevacizumab, increasing the amount of chemotherapy that we were giving to these patients to almost dangerous levels and induction mortality at a high, or trying out maintenance strategy. All the trials in the last 20 years have failed to improve the outcomes of RCHOP. And that is the reason why, as we go ahead, we will have to use the evolving technology if we have to improve the outcomes of the rarer types, the intensive types, and the more aggressive types of large B cell lymphomas. And this is to show you the same thing, that the number of DLBCLs NOS has reduced because now we have many molecular and cytogenetic tests available, and we need to actually diagnose them correctly and then treat them correctly rather than to give everybody the standard R-CHOP backbone. So what has happened in the near future, the immediate future, present, and the eventual future is we are going to need not the cell of origin so much, but definitely the molecular and the genetic testing. And perhaps the only way to get all of this done quickly will be through the NGS platforms, which are slowly becoming available. So if we look at the very simple concept of cell of origin, we had the activated B cell DLBCLs with an increased NF kappa B and BCR signaling and inferior outcomes to R-CHOP. We had the germinal center B cells, and we believe they had a superior or a good outcome with R-CHOP. And then there was a third area, which was a small number, but there were definitely some that remained unclassified between the very simplistic cell of origin concept of dividing all DLBCLs into ABC and GCB. And this actually happened because we realize now that in the germinal center, there is a dark zone and a light zone, and the kind of oncogenic uh, changes that happen are different. And so, if the germinal center B cell lymphoma arises from the dark zone, it does poorly. And so, not all germinal center B cells have a good outcome. There are some which do not have a good outcome. And this is with the further understanding of the differentiation as it happens of the lymphocytes as they move through the germinal centers. So, sometime back in 2021, a comprehensive genomic analysis of the primary DLBCLs was done in a cohort of about over 300 patients. And the goal was to define DLBCL genetic substructures. And it wasn't only the structural variants like BCL2, BCL6, and the MYC that made a difference in the outcome, but they realized that there were many more recurrent mutations as well as somatic copy number alterations, which actually made a difference in the outcome of the B cell lymphomas. And so they came up with this genetically distinct DLBCL, what should I say, sub-classification of a classification of a classification, which now puts the DLBCLs into 5 clusters from C1 to C5. And very easily you will realize that C1 is an ABC with a favorable outcome, and C3 is a GCB with an unfavorable outcome. There were two groups working at the same time, the genetic DFCI, which is the Harvard group, and the NCI, which were, they looked at more or less similar oncogenes and were able to put these DLBCLs into 5 categories, or the NCI classified them as BN2, EZB, ST2, and MCD, depending on the gain, mutation, or the alteration in one of the oncogenes. And for a long time, we have known that this work is being done extensively at the laboratory level, and they have been looking at what we now call as the good ABCs and the bad GCBs. And I have just shown you which are the good and which are the bad ones. So we have ABCs also which do differently. The ones which are C1 do much better than the ones which belong to the C5 genetic alteration group. And similarly, there is a slight difference in the GCBs also. The ones which arise from the dark zone do poorly as compared to those which arise from the light zone of the germinal center. The C2 remains a entity which is kind of independent of the cell of origin, and it has a biallelic inactivation of P53 and behaves more like an indolent lymphoma over the years, with a tendency to continuously keep relapsing, unlike the other DLBCLs, in which after a certain time period the curves plateau out, and we feel that almost 50% or 60% of these patients are cured. So, how do we compare the ABC and the GCB with a small area of unclassified to the Harvard and to the NCI classifications is shown on this particular slide. And it is totally dependent on the oncogenes that are expressed, overexpressed, and the translocations that we see in these systems. More recently, and this is a paper which was recently published in Blood about a month ago, the Harvard group has shown that the DLB class is a probabilistic molecular classification and may guide clinical investigations and practice in diffuse large B-cell lymphomas. And they have actually done this work using a neural network-based probabilistic classifier to assign DLBCLs to its respective C1 to C5 genetic subtypes. And in future, this of course will provide actionable genetic information for most of our DLBCLs. And you will realize that the very simplistic cell of origin has overlaps in almost every subtype of the C1, C2, C3, C4, and C5. And the poor prognostic C3 and C5 actually still form the largest number of patients that we see, and a lot more work is to be done. How does DLB class compare with the NCI classification? There is a large area which is others still in the NCI classification. So I think much more work will be required, because I'm sure as the NGS gets more and more reformed, we are going to find more relevant genetic abnormalities which will have an impact on the outcomes of lymphomas. So if I have to sum up this paper, it very clearly shows that recurrent genetic alterations in DLBCLs identified 5 discrete subtypes almost 5, 6 years back. This particular paper has validated the taxonomy in an independent data set and expanded the series of 699 primary DLBCLs to develop a molecular classifier, and now confirms the performance of this particular classification, or one may call it sub classification of the B cell lymphomas. And for the future, it says that this classification enables prospective classifications of single cases for inclusion in genetically guided clinical trials or practice, and represents a framework for the development of genomic based classifications in other cancers as well. So this is kind of going to be, like I always feel very proud to say, lymphoma has been the front runner of management of many cancers in the past, and I think for the future also. So this has been a little heavy. Let's come down to what is more realistic. The next is the Hodgkin's lymphoma. We all know that it accounts for 10% over the year. Over the years, we have realized that there are two subtypes, the classical and the NLPHL. The classical Hodgkin's lymphoma forms 95% of the patients, and we still continue to have our pathologists classify them as nodular sclerosis, mixed cellularity, lymphocyte predominant, and lymphocyte depleted. By and large, at the turn of this century, we realized that this is a B cell malignancy, and the classical Hodgkin's lymphoma also expresses CD30 and 15 and is negative for 45. If this molecular or morphological classification of relevance today, if you look at the outcomes of stage 3 and 4 Hodgkin's lymphoma, then we know that ABVD has done fairly well for the last 60 years. The addition of brentuximab, which is the anti-CD30, has improved these outcomes. And today, almost 90% of the patients of stage 3 and 4 Hodgkin's lymphoma are cured and well beyond 6 years. We also have other molecular drugs which have come up, the checkpoint inhibitors, and a more recent trial with a shorter outcome is addition of nivolumab to patients who receive AVD. And at the end of 2 years, definitely the outcomes are even better than those with brentuximab. So more or less, the morphological classification of Hodgkin's lymphoma doesn't really help us in treating our patients. But is that really the end of doing molecular testing for this? No. The very first thing that we realized that it is a B cell origin tumor is because we continue to look, despite excellent outcomes, at the um, genetic changes which happen in a patient of lymphoma, whether it is in the cell or it is in the environment. And there was information about activation of oncogenes and the immune evasion that is characteristic of Hodgkin's lymphoma. So we realize there is a large array of chemokines, growth factors. There is the immune escape, which is facilitated in patients of Hodgkin's lymphoma. Of paramount importance, what has come out of these studies is the expression of immune checkpoint inhibitors, that is the PDL1 and PDL2. And this has been now therapeutically exploited. So we have phase 2 trials of patients who have relapsed using a checkpoint inhibitor with chemotherapy, and their progression-free survival at 2 years is unimaginably high at 87%. Remember, these are relapsed patients, or some of them are progressive patients on treatment, and their 2 year overall survival is at 95%, something that we didn't even see upfront for first-line therapies for a long, long time in most cancers. The next thing is that how can we reduce the toxicity, especially in elderly patients who relapse? And so checkpoint inhibitors with anti-CD30 again shows more or less similar outcomes. That is 36 months overall survival at 95%. So if you really want to reduce the toxicity at the cost of financial toxicity, we also have this approach where we can use these two drugs and put most of the patients who have relapsed into long-term outcomes without major toxicities, without transplants, and without the need of CAR T cells. What about nodular lymphocytic predominant disease? This is a CD30 and 15 negative, CD20 positive lymphoma, and is actually on its way out from Hodgkin's lymphoma. Because if you look at the patterns, and especially the D, E, and F, it is more like one of the B cell lymphomas rather than a Hodgkin's lymphoma. And it was a lot debated in this particular uh, edition of WHO 5, whether we should move it into the low grade lymphomas, but for the time being, to maintain historical relevance, it remains. But I think by the next edition, it will move out. So, Amit, you can tell me the time if I'm overshooting.
Ma'am,
So,
perfect. Please go ahead, ma'am.
If we look at the future, these are extranodal marginal zone lymphomas. For a long time, we have known that if it is a single organ involvement, these patients can be safely kept under observation after an appropriate antibiotic has been given. So we call them stomach marginal zone lymphoma, lung marginal zone, ocular, salivary, thyroid, and skin. And these patients remained under lifelong follow-up because they were low-grade lymphomas, and we knew 20 years, 25 years later. But sometimes these patients are likely to relapse. And it will be interesting if we actually know what are the pathways activated, and if a certain kind of treatment can be given when these patients, especially in the younger patients, if you can treat them at that point of time and then spare them of this fear that one day it will come back. We don't know in 2 years, 20 years, or 25 years. So the molecular classification is actually going to be able to help us to find targetable treatments which may actually eradicate this uh, stage 1 disease and spare young people from the number of scans or the number of follow-ups or the number of blood tests that they need throughout their lives. I think this is the last subtype that I will take in the new classification. We have known that immune deficiency dysregulation associated lymphomas is a new group over here. In the prior classification, they were considered as primary immunodeficiency, HIV infection, post-transplantation lymphomas, or iatrogenic. The new nomenclature builds on an integrated approach for these lymphomas, which is the histology for certain, the presence or absence of oncoviruses, and the background of immunodeficiency, which includes inborn errors of immunity, HIV infections, the post transplantation lymphomas, the autoimmune disorders, and iatrogenic post chemo treatments for solid tumors and those that will happen after CAR T cell therapy are now all included in the immunodeficiency dysregulation associated lymphomas. So, what was all not a part of the previous WHO classifications now has come as an entity and is subclassified as either hyperplasia arising from immune deficiency, polymorphic lymphoproliferative disorders, and lymphomas arising in immune deficiency and includes the patients who come with HIV. Uh, there is not too much in T cell lymphomas yet because a lot of work is still ongoing. The only thing that I think is of importance is this entity, which is nodal T follicular helper cell lymphoma, which is a definite phenotype of T cell lymphomas and is seen in all the three nodal subtypes, which is angioimmunoblastic, follicular, and the nodal peripheral T cell lymphomas and of some importance because for some time we believe that giving them HMAs as therapy may help them to be controlled better than the standard therapies that we have been doing. Still a debate on that, not absolutely confirmed, but work goes on in this area. So what have we done over these classifications is not to confuse the clinicians, which used to be my first fight with all the pathologists. But the morphology told us that Hodgkin needs ABVD and the other non-Hodgkin's lymphomas need COP or CHOP. When we came to know they were low grade versus high grade, we gave COP to low grade and CHOP to the high grade patients. When we came to know there were B cells and T cell lymphomas, we gave rituximab to B cell lymphomas, and now most recently we have started giving anti CD30 both to Hodgkin's and to the T cells which express CD30 on their immunohistochemistry. We have used risk adapted therapy for a long period of time and reduced therapies in those we found good results depend with the PET as a image to understand if the patients had done really well early on, then we could reduce the therapy. So basically, patients were put into protocols and we use risk adapted depending on morphology, the use of immunohistochemistry, and the use of PET to de-escalate therapies. What we now go forward is towards biologically informed lymphomas. So in future, we may use these 5 clusters of molecular signatures, exploit associated survival pathways in animal model, and then develop the uh, rational therapies for each one of our patients, which may be different in the times to come. And so from the regular R-CHOP based backbone, now with the addition of Pola R-CHOP, what will happen for the future is the protocol based therapy will take a backseat and there will be more precision cancer medicine utilizing some of these new platforms which are being tested. And already we have the results of the guidance uh, trials from China, which are actually phase 2 trials in which they have used RCHOP as the backbone, and then they have added one of the targeted molecules from the NGS platforms, which shows us which is the pathway which needs to be targeted. And their initial phase 2 results suggest that that may be the way to go forward. So while your RCHOP remains your first cycle, as soon as your NGS reports are available, you add the RCHOP X. And like I said, the initial results have been a little encouraging. Wait till randomized trials are available to actually say that we have made a difference. So for the future, it's not going to be FNSCs anymore. Ideally, an excision biopsy, if it is not possible, a good incision biopsy, because it is not only follicular or diffuse involvement of the lymph node, but you need good IHCs, sometimes a second and the third panel to be able to classify, subclassify, subtype, and finally genotype or phenotype these lymphomas. We have no doubt that anybody who has an aggressive looking DLBCLs needs to have a FISH analysis done and they need to be treated more aggressively. NGS will come up in the times to come. Maybe it will not be as difficult as it sounds today, and maybe as we are trained by our pathologists and molecular pathologists, we will become better at it. Always remember there will be lymphoid preponderance or hyperplasias. Don't label those patients as lymphoma. You may still need to do clonality in B cell and T cell if you are uncertain that this is a lymphoma, especially if your pathologist tells you that I am not happy to call it a lymphoma. So with that, thank you very much for your patient hearing. I really want to thank Dr. Borges, Dr. Naresh, and Dr. Sumit Gujral from Tata Memorial Hospital, where I spent 25 years and who actually got me initiated into lymphomas and actually taught me lymphomas. I used to only fight with them that they want to make the life of clinicians difficult. But today I realized what they mean to the change in the lymphoma treatment as it has happened in India also. I also want to thank my present colleagues, Dr. Zamir, Dr. Indu, and Dr. Bhagwat. They sit in the lymphoma MDTs, and every day we chew their brains, and they are very patient with us and continuously teach us. Still, they teach us morphology, and still they teach us how to actually subtype these lymphomas. Like Dr. Basu correctly said, the clinicians sometimes take away the credit of patients getting cured after transplants, but actually these are the people who prevent many of the patients from not going for transplants unnecessarily when they tell us, be gentle with your patient. I don't think this is aggressive. So thank you for your patient hearing. And Dr. Basu, I'm going to need a lot of help if there are pathology questions because I am a clinical observer of the evolution of these classifications.
Yes, ma'am, I'm around. I'm around. I mean, we can
Thank you.
chew each other's heads also. That's how we grow. Hematopathology is that way so good.
Thank you so much, ma'am, again for a fantastic and wonderful lecture. As always, it's always a good learning from you. And I now request all our discussants to please put the hand raise signs so that we can start our question answer session with both Dr. Professor Basu and Dr. Dinan, ma'am. Yeah.
Yeah, this will be the first of its kind when we need the chief guest more than the speaker.
No, no, not at all.
So before the questions keep starting, ma'am, I have one question regarding the immune privileged sites, DLBCL, which is another category. Is there any way that treatment is different for those categories?
Yeah, there's a small slide which I didn't emphasize on. If you look at the genetic level now, the Hodgkin's lymphoma, the primary mediastinal B cell lymphoma, and the CNS lymphoma and the testicular lymphoma are the ones where we see a lot of PDL1 activity. And so, if the initial outcomes of DLBCL with checkpoint inhibitors have been disappointing for relapsed refractory disease. But in all these lymphomas, if you use checkpoint inhibitors in the relapse setting, you find that the responses have been fairly good, especially in Hodgkin's lymphoma. And this is being seen in the CNS lymphomas and in the mediastinal lymphoma and also in the testicular lymphomas now. So this is what we have learned after putting them together in one group. So for relapsed setting, I think this is to be treated differently from how we treat the diffuse large B-cell lymphomas.
Thank you, ma'am. And the second question is regarding the use of acalabrutinib and BTK inhibitors upfront in the treatment of DLBCL. Any subgroup of patients who are using right now on a current basis in clinical evidences that we can go upfront for such some subtypes of lymphomas with the use of acalabrutinib along with
So,
RP.
so again, if it is going, I mean, I honestly don't do it. I'll tell you why. Because the data is all phase 2 just now. And if we add these drugs to the R-CHOP regimen, it becomes pretty toxic. And then what happens is the dose intensity of R-CHOP is not maintained. And we know that if we don't maintain the dose intensity of R-CHOP, patients will go into response. But if you look at the 5-year data of patients who have had dose intense therapies with over 85% of the myelosuppressive drugs versus those who have had either what we call as mini CHOP or reduced intensity CHOP, the difference is 20% at 5 years in our own data. So I am reluctant to presently change. But if you look at the guidance trials where we have started discussing R-CHOP plus X, what they do is the first cycle is R-CHOP, and then you send a sample for NGS, and when the results come, and if you find that there is activity of the BTK pathways, the BCR signaling, then the X that you add will be a Bruton kinase inhibitor, or you will add venetoclax, or you will add, so many other drugs which we have used in the past also. But when we add in these subtypes now, perhaps we will see a better outcome than when we saw in the protocol-based therapies of the last 20 years, where we added bortezomib to all, lenalidomide to all, and we did not really subclassify them into the uh, the subtype where the expression of these oncogenes was more. So now, as we refine the trials, perhaps we will. In phase 2, outcomes are good. If you read the 2 guidance trials, both for B cell and T cell, there is a definite improvement in the outcome. What they do for those in whom we still don't find an overexpression is to add HMS, either azacitidine or decitabine, and then look at versus R-CHOP. These results are still to mature, and the other thing is we still need randomized trials before we start taking these actions. So upfront, honestly, if someone can afford Pola, I don't go beyond Pola R-CHOP. Most of them are R-CHOP still, and maintaining the dose intensity, which to me is perhaps the best we can do for our patients. As trials mature, definitely we will look into the data and then add the X, which may be acalabrutinib for patients with BTK pathways.
Thank you, ma'am. There are certain questions related to ma'am regarding the triple hit and double hit lymphomas. In younger patients, we usually focus on double hit and triple hit lymphomas, and we do tests for the c-MYC antigen. And if it is double hit or triple, the best treatment should be dose-adjusted R-epoch. The questions which they have asked, or most of the audience have asked, that whether in elderly people like 70, 75, 80 years of age, do you really test for double hit, triple hit lymphomas? And if they found positive, are you differing from R-CHOP or R-mini-CHOP and going for dose-adjusted R-epoch in elderly population also?
Okay, so this is our style of precision medicine, no? Age and costs and so many other things is our precision still. So let me tell you what has happened. First is that when the new WHO has come up, and over time we realized that patients of DLBCL with MYC translocation do poorly. So we started looking at what else makes it worse. And we thought that it was BCL2 and BCL6. So the first change that has happened is BCL6 doesn't impact, and so it is only double hit now. There is no concept of a triple hit lymphoma. So if you have MYC and BCL2 translocations, these are double hit. Young patients need to be treated more aggressively, and more aggressively doesn't mean that we need to do a high dose chemotherapy and auto transplant, which many people ask. And actually, that hasn't really shown a difference in the outcome. Again, to say that dose adjusted epoch is the standard care, no, because there is no randomized trial in double hit lymphomas to say dose adjusted epoch does much better. If you look at early stage disease, I don't change the treatment from R-CHOP. Early stage double hit lymphomas also, there is no difference in the outcomes, at least from real world data that is available. So it is only the stage 3, stage 4 high risk patients with a large number of extranodal sites involved are the patients in whom we give the dose adjusted epoch regimen in. Patients tolerate up to 65, 70, there is no problem. In the patients who are over 60, generally we don't start with the standard dose. We go one dose below. That means dose minus one and start. If they tolerate that, we come to the first dose and then we don't really escalate. So I won't say dose adjusted, but we do try to give them epoch if they are proven double hit. And who are the patients in whom we suspect and do the translocation? Not for all patients. It is those who have a very high KI, those who have a very high c-MYC on the IHC, that means over 40% c-MYC expression. And again, like I said, stage 3, 4, very high LDH, lots of extranodal disease. Those are the patients in whom we do the translocations. And if they come as double hit, we definitely like to go for dose adjusted epoch. Beyond 80, if the patient is there, then I respect age. So then I really, you can try the dose adjusted epoch, but if you go down -2, I think you are just giving them side effects and not doing anything very much. So yeah, it is standard CHOP. If you look at, there is only one thing that gives us satisfaction. There is one data which they have analyzed in the US, which comes not from institutes, but it is actually from the insurance companies. They looked at dose adjusted epoch versus R-CHOP they gave the data for somebody to look. And honestly, they say there is no difference between R-CHOP and dose adjusted epoch, even in double hit. So there is a long way to go in the high grade lymphomas.
Thank you, ma'am. Another question has been asked by Dr. Emon Tent. In a patient who is PAX5 negative Hodgkin's lymphoma, how can you differentiate from anaplastic large B cell lymphoma, which also comes as CD15 positive, CD30 positive, ALK negative, if T cell receptor gene rearrangement is not visible? I think Basu sir can answer that.
Dr. Basu, can I take your help?
Yeah.
Yeah. Okay, differentiating Hodgkin's from ALCL. Again, let's start at the morphology level. ALCL, generally, those large cells are in sheets or in groups. In Hodgkin's, they're all scattered. And ALCL, I would think, is anyway a T cell lymphoma. So some of the T markers would be positive in those large cells. It's very unlikely that there would be CD3 negative or CD2 negative, CD4 negative. And then when we compare it with Hodgkin's. So that's the first point. So T cell versus Hodgkin's is generally negative for both CD20 and CD3. CD15 positive ALCL is also very uncommon. ALCLs are usually CD30 strongly positive, ALK positive. So I suppose if we look at the entire picture from morphology to the IHC, we would be able to pick up, differentiate a Hodgkin's from an ALCL. And as I hope you're aware that in Hodgkin's lymphoma, the RS cells are weakly positive for PAX5. Don't expect a very strong reaction to PAX5 in the RS cells, because it's a crippled, as we know that the morphology, it's not a very strong. So you compare it with the background B cells that are there, compare the intensity. So it may seem negative, but may could just be a weak expression, which we can miss out on a routine examination. So I think that's a way to go about it.
Thank you.
Translation may help for ALCLs, the 2-5.
Yes, definitely. Then cytogenetics and karyotyping would help.
True. Thank you, sir. Dr. Gopinathan, your question.
Yeah. So good morning, ma'am. Good morning, sir. It was a very nice discussion. I mean, it was put so concise. Yesterday, we had a multidisciplinary board discussion, sir, where they were discussing about a case of primary CNS T cell lymphoma. The clinical presentation is a frontal stroke, and when they did a biopsy, the markers were CD20, BCL2, BCL6 per negative, and CD3 and 5 positive. So how common is primary CNS T cell lymphoma? Have we come across?
So I've seen this, and it is very rare. So if you look at the primary CNS lymphomas, almost 85 to 90, or maybe even 95% of them are B-cell lymphomas. Generally, they are large B-cell lymphomas, and most of them are GCB subtypes. That is what we know about the primary CNS lymphomas. They're very rarely I can't remember exactly how many we have in our registry, but if let's say we have 50 patients of primary CNS B cell lymphomas, we have seen one Burkitt's, one low grade malt-like, one T cell. So these are very rare, but it's not unknown to see it. And all that we do for primary B cell lymphomas is to give them whatever high dose methotrexate, and we do give them rituximab. We haven't changed the treatment for that occasional patient, except that we didn't give him rituximab. Otherwise, we followed the same lines of treatment. What is the outcome of that patient is something I don't remember, but I know for certain there is one or two patients over the last 10 or 15 years that I have been here and maintaining a registry.
Yeah. The only odd thing that I found with the case was the KI that they reported was only 40 to 50%, ma'am. So will that be correct? Like for T cell lymphoma, will the KI of 40 to 50% be okay, or it should be even we should expect even higher?
So again, Dr. Basu will help us, but 40 to 50% KI for T cell should be okay. I would not think that it necessarily needs to be in the range of, because that is what I think would be there for the PTCL, NOS,
Yes.
and others. But I
PTCL
will
can
ask.
have a variable. It's generally high, but 40 to 60% is a good Ki67 to have for a T cell lymphoma.
Thank you. Thank you, sir.
Thank you, Dr. Gopinath. Dr. T. Ramadevi.
Good morning, ma'am, and good morning, sir. I have a case in my institute, stomach biopsy, middle-aged men with large cell lymphoma, monomorphology. And when we did the markers, it had a dual marker expression. CD20, CD3, both were negative. CD30 is coming strong. And BOP2, OCT1, everything is coming, PAX5 is coming. Along with that, CD7, CD5 are also showing a good expression, that we cannot ignore that. So it's like in that case we gave two options, like ALK positive large B cell lymphoma versus ALK positive ALCL, and we advise it for the gene rearrangements. So in such cases where we are not able to decide only with the morphology and IHC, how will you treat this patient? Would you wait for the gene rearrangement result, or would you take it as, because ALK positive LB cell, they tell it is a rare thing. So do you treat it as ALK positive ALCL, and then if no response comes, then you go back to B, or how you approach this case? Because I'm very curious to know how the clinician would treat in such cases.
So clinician's approach is very simple, but I'll ask Dr. Basu if he has some thoughts on the diagnosis first, and then I will.
Yeah. So, Dr. Ramadevi, it was B cell markers were negative.
T cell CD3, matlab lineage marker was
No.
negative.
T
CD3 was
marker,
negative.
CD3 was negative. What about the B marker? What was it positive?
CD20 is negative, but we are getting CD10, and then we are getting ALK positive. CD30 is coming positive, and BOB1, OCT2, all those are coming positive, indicating PAX5 is positive. So that is one
PAX5
more.
is strongly positive. Okay, so you're dealing with a B cell neoplasm.
B cell, but we are also getting an HS and a
ALK1.
CD7 and also CD5 expression, CD4 like that. And we did the kappa lambda. Lambda was coming, lambda restriction is there. But the fight is like whether we call it as ALK positive LCL or ALK positive LBCL. So we gave two possibilities and advised it for gene rearrangement. IJ gene, it comes means we take it as B. TCR means we take it as ALCL like that.
Understood.
But in such case, if we give like that, how the clinician would treat them initially?
Yes, I understand. You are
It is
very
a stomach
sure that the
biopsy,
CD5,
extranodal.
CD5, yeah, understood. CD5 and 7 are not in the background T cells. They are in the tumor cells.
They are in the tumor cells. And these CD7, CD5,
Tumor
when I
cells, you're
study
sure
the
about that.
articles, ALK positive LBCL can express as an aberrant marker.
Can express, definitely. Yes. CD7 is known to be expressed by B cell neoplasms, definitely. So I think we will leave it at that. Pending gene
For gene
rearrangement could be
rearrangements.
either B or T, depending on. It would be. If I see PAX5 positive, I would rather put it as a B cell neoplasm.
That is what
So.
they were ready to put it as T, but I was requesting my sir, no sir, this is having the B cell marker. PAX5
Yeah,
is coming.
so I
Lambda
would
is
put it
also
as
coming.
B.
We can't ignore that. So we
Yes,
finally came into the thing like we put it as all positive large lymphoma, B cell versus T cell advised gene rearrangements.
that is putting the clinician into more trouble.
That is what. So
I
I
think.
wanted to know how the clinician received it and how the clinician would start the treatment initially in this case particularly.
So, treatment starting is simple. How old is your patient?
Middle age, ma'am.
Yeah.
Okay.
Stomach biopsy.
So if you are associated with a good lab, and for us, we get all these reports within 15 days, including clonality,
Okay.
then we always have this thing, no, to start with a pre-phase chemotherapy. You can choose. If you're very sure that it is B cell, you may put rituximab. Otherwise, you start with the pre-phase. It takes care of the immediate problems of the patient. That means reduces the disease, no tumor lysis after 3 weeks of waiting, the chance of perforation, bleeding, everything will come down by the time you're ready to start your full-blown therapy. And then if it comes as a B cell clonality, obviously you will add rituximab to it and then discuss the possibility depending on the stage of this patient, whether they want to also go in for pola R-CHOP. That is one way of looking at it. Let me tell you, there is one point of time when we also found when we finished clonality, both B and T cell clonality were present. And we have a couple of cases like that. And honestly, I don't know, and I didn't get any help any further after that. I guess when we have better technology, that will also be sorted out. These are very rare cases, no? 3.5, 4,000 patients, only one or two like that. And you then, kind of use your best. In your case, the B markers are so strongly positive that I will go ahead with R-CHOP.
Ma'am, one more doubt, ma'am. In this case, CD20 is negative, especially all positive LBCL. CD20 is negative. So rituximab will not work here.
So what we've done in such patients is given, in the recent past, given them polar CHP.
Polar CHP.
Polar is something, that goes across the entire differentiation of B cell, almost from the beginning till the peripheral, from marrow till peripheral blood. That's an antigen which is expressed on most of the B lymphocytes. So then in the last 6 months, when we had a CD20 negative B cell lymphoma, that is what we have done.
Okay, ma'am. Thank you, ma'am.
Thank you, Dr. Ramadevi. Dr. Rashmi Kushwaha.
Good afternoon, ma'am. A very wonderful and elaborative talk. Good afternoon, Basu sir, and good afternoon, Amit sir. My question is like regarding these days, we are getting mostly the core biopsies from the lymph node. And then it becomes very difficult because by the time we finish putting up all the markers, the biopsy tissue is exhausted. I will share an experience. We had a patient, we received the core biopsy, middle-aged female patient. 20 was positive, 10 BCL6 was positive, and KI was around 60 to 70%. So, based on these markers, we labeled it as diffuse large B cell lymphoma. Patient was put on standard chemotherapy, but after 6 to 7 months, she has developed another submental lymph node. Now, this time I have again received the biopsy from the same patient, the core biopsy, and this time 20 is positive, but 10 is negative, and KI is coming low, 20 to 30%. So, it's like really a problem whether to report it as a relapse or whether it was something else. So your opinion on this kind of cases where we receive the core biopsy and like in this patient where the patient has relapsed.
So we'll take Dr. Basu's opinion on what kind of tissues they want, and then I will kind of tell you. There will be
There'll
reasons.
be a stray cases where core biopsies are sent to us, but generally it's good to have an excision. That's excision biopsy and intact node. But of course, depending on the clinical scenario, if a big node is there or a mediastinal node is there, abdominal node, the clinicians have no other choice but to send us a core biopsy. So approach to a core biopsy is that we have to be very cautious about our tendency for our technicians is to trim it as much. So we have to give instructions that this is a precious tissue, see that not much is wasted, so that we could go ahead and do markers. The problem with core is that depends on, if it's taken from a necrotic site, where there is necrosis or where there is more of desmoplastic reaction. Those are the drawbacks of core. So that we have to understand. But generally, this problem occurs not very regularly. Most cores are, sufficiently cellular with abundant material for us to do histochemistry. Regarding your case of Ki67 going down in the subsequent, these expression of these antigens are also dependent on the therapy given. That also has to be taken into account. Lack of tissue, necrosis in the tissue, angiogenesis or edema in the tissue are all possibly chemotherapy related. Could also be kept in mind. Should also be kept in mind when we are interpreting. These are definite limitations of core biopsies that we can't help it always too.
We'll consider this as a relapse.
Yeah, if you see a good population of CD20 positive cells again, it is definitely a relapse.
Fine, sir.
Definitely a relapse.
Sir, the reason behind CD10 becoming negative is?
I'm not sure. I'm not sure. I mean, another issue with what we have experienced with post-therapy marrows is the antigenic expression doesn't remain as optimal as the previous, as the de novo lymphomas. That is something that we have experienced both for leukemias and lymphomas on relapse or in post-remission marrows. The other possibilities are different lymphoma arising altogether again. I do not know. That has to be taken in the context of the case.
But
Reena ma'am,
if we consider the probability of different lymphoma arising, then is the treatment going to change in this case?
So it still remains a CD20 positive.
Positive.
So the management will continue on the same lines as a CD20 positive. Depending on the time from his first therapy, this is almost like progressive disease on treatment, right?
Yes. So should be treated as salvage only. We need to again go for a relapse case only.
Yeah.
I
Yes.
suppose so.
Yeah. But my request will be to all the clinicians, you have to make friends with the surgeon again. We have become so fond of core biopsies. We are going to need good tissue. We are going to need to keep tissue for future references
Yes,
also.
definitely.
And
Definitely.
in a submental node, I think we should insist, peripheral nodes, we should insist, especially if they are not very large, to get a excision biopsy
Entire node.
or at least an incision biopsy. The surgeons feel we are wasting their time, but for us now it is becoming extremely important.
Very
There
true.
will be still situations when the fellow will be gasping with a large mediastinal node. All that you will get is an FNSC. Don't not treat that person because that guy still has a 60% chance of cure without. So that is the only exception I would make. Life-threatening SVC
Situations,
over the
yes.
weekend. Otherwise, we normally do a core biopsy. We ask our pathologists if they feel the tissue is adequate, and then we give the steroids or the CVP. We avoid giving unless they are happy with the amount of tissue they have received in a core biopsy. So there is no urgency to treat a lymphoma, except maybe fear that they may go to another center and start. But I think that is better than doing a bad job.
Thank you, ma'am. Thank you, sir.
Reena ma'am,
Yes.
in the ALK positive large B cell lymphoma, WHO has given like CD30 positivity will be very less, like around 30% cases has shown. So in that case, if it is coming positive still, would you advise the brentuximab? Would you add to it Pola-CH?
I am honestly not sure what if I will add it upfront. T-cell lymphomas are known to have CD30 positivity in
ALK positive ALCL, it
or
has.
FCOS. So normally what we do is ALCLs, it is known. The entire Echelon trial is on ALCLs as the backbone. The other patients of T cells were very few, and that definitely shows that there is a difference in outcome. If the B cell clonality comes positive for this patient, I will definitely prefer to go with as a B cell lymphoma, knowing that ALK positive B cell lymphomas don't do well. And if the patient relapses at that point, perhaps. I've honestly never used CD20 and CD30, anti-CD20 and anti-CD30 together. But now there are so many, bites coming in, and there are so many monoclonal antibodies being given in combination that maybe we can do a little bit of literature, and you may find somebody has given it. I haven't.
Okay, ma'am. And primary cutaneous CD30 positive you have used, ma'am, brentuximab.
So primary cutaneous CD30 positive ALCL, correct?
No, ma'am. CD30 positive T cell lymphoma. Primary cutaneous, but
How much is the disease?
mm, they are rare only, but in that case, matlab, targeted therapy may could it be extended more than the ALCL, that brentuximab?
So with primary cutaneous, you have to be a little careful. So let's say it is primary cutaneous ALCL, yeah, ALK negative, and it is a very localized disease which can either be surgically excised or you can give local treatment. That is more than enough. We always fear that it is ALCL, ALK negative, and so this is a bad disease, and so we must do everything right up to. No, if it is localized, you can get away with local therapy, and these patients do extremely well. So that is one. Then you have the CD30 positive T cell cutaneous. This is also a new entity which has been defined now in the WHO. And if it is systemic disease and you need systemic therapy, definitely. If it is cutaneous and localized, then I am still comfortable watching the natural history of this disease because these are relatively low grade CLPDs. If it is a DLBCL cutaneous, then I would go all out for food therapy. So cutaneous lymphomas actually needs rethought with so many treatments available and the need for least therapy if it is a localized disease.
Okay, ma'am. Thank you, ma'am.
Thank you, Dr. Ramadevi. There is one question from Dr. Durga. What should be the cutoff percentage for MYC, BCL2, and MUM1 expression to be reported on bone marrow biopsies? Are there any established guidelines regarding the use of these cutoffs in the bone marrow immunohistochemistry reporting? And additionally, how reliable is Ki-67 assessment by IHC on bone marrow biopsy specimens?
So again, I think that comes to me.
Absolutely.
No, Durga, I presume it's a case of a primary lymphoma of the marrow that you're talking about, or the primary presentation in the marrow, when you need to do these markers. I don't think there is any cutoff as such that has been given for these specific markers in trephine biopsy. I am not aware of it. So I really don't know. I mean, you could look it up. I don't think there are any cutoffs. So if your processing of a trephine biopsy is good, then I think you could rely on the marker, especially Ki-67. We have had with our Hammersmith protocol, we have had no problems about doing Ki-67. A thin section, well decalcified, well fixed. Ki-67 works very well. In fact, I still remember one case where we had a CLL and a Richter's transformation in the same marrow. Ki-67 beautifully demonstrated the strong positivity. However, I mean, that's another thing for a trephine biopsy. You always have to keep in mind that there are the background normal myeloid cells and normal lymphoid cells, which could also take up the marker. So you have to be very careful about which area you are looking at and kind of the morphology of the cells. So that's all. I'm not really aware of any cutoffs for these markers. So I do not know that.
Okay, sir. Thank you, sir.
Thank you, Dr. Durga. So there is one question from Dr. Shilpi. In patients coming with for splenomegaly with pancytopenia, after excluding the infective causes, opinion comes to the hematologist, and the hematologist does the flow cytometry from the bone marrow as well as from the peripheral blood. And what was seen was in one of his cases, clonal B cells are positive, which is about 1 to 4% in peripheral blood, as well as in the bone marrow aspirate, number one. And these cells are CD5 negative. Patient was given BR, that is bendamus rituximab, and that led to resolution of splenomegaly. and recovery of blood counts. Question is for Dr. Rina Nair, ma'am. Your experience dealing with such cases?
So, a large number of splenic marginal zone lymphomas is what is seen: large spleen, marrow involvement, and marginal zone lymphoma is more or less still. Dr. Basu may agree or not, but it is still like a low-grade CLPD, more like a dustbin diagnosis. When you have ruled out
Yes,
all the other
very
CLPDs,
true.
then you
Very
call
true.
it marginal zone. And
Very
this
true.
particular entity in the WHO new one is actually increasing with many other subtypes becoming a part. So anybody who has a splenomegaly is a splenic low-grade B-cell lymphoma. Treatment-wise, I think you have done well and your patient is doing well. So that is the way you would go, because pancytopenia is definitely an indication for treatment. And earlier on, we used to see that, earlier on, we used to do a lot of bone marrows, which we don't do now. And
Yes.
so for patients with large spleen who were treated the with even splenectomy at that point of time, we didn't have too many drugs also. After some time, when we did the bone marrow, we realized that the bone marrow was also normal, which doesn't happen in most of the other lymphomas. So it is the splenic lymphoma which is the driving force, and that's why you were getting the marrow involvement. And so with the local therapy, we used to get away. So with these therapies that are now available, it's you keep the spleen, you treat them, and you have to continue their surveillance for the rest of their lives, because it is a low-grade lymphoma. It will come up at some point of time. And so we have to continuously monitor them. And monitoring this patient is easy, just the spleen clinically and the CBC.
My one question in this is, even with 1 to 4% of marrow involvement, would you still treat the patient? I mean,
No,
this particular,
I would not treat for the marrow involvement, but a spleen that is causing hypersplenism and
that way
pancytopenia,
you would treat. All
then
right.
it was a normal count, or even it was a high count with a peripheral spill, and the patient is asymptomatic and a relatively small spleen, I would still keep them under observation.
All right. All right. Fine.
Thank you, ma'am.
Another question has come from Dr. Babita Sodi. This is from Rina Nair, ma'am. Out of the whole list which you showed, ma'am, today regarding the classifications, which classification to follow, which can be treatment oriented?
Okay, so that's see, we have to follow the WHO
Yes.
4 for certain, because that is mainly morphology, IHCs, which is a must. We cannot get away from IHC in today's world. I still agree that Dr. Basu will say I can, diagnose Hodgkin's versus non-Hodgkin's in 80% of the patients without need of anything. That is correct. But when it comes to non-Hodgkin's lymphoma, then to start finding out which is marginal zone, which is mantle cell,
Yes.
which is DLBCL, is very important, because mantle cell lymphoma in a young patient will need intensive therapy, RSC-based therapy, and a transplant, maybe BTK inhibitors and maintenance. DLBCL requires its standard treatment, and low-grade lymphomas from watch and wait till treatment is indicated. So it's really difficult to say that, we can manage only on morphology. So IHCs is
No,
a
you cannot.
definite must. Cell of origin has disappointed us when we look at the Hans algorithm and we try to say CD10 positive are GCBs and MUM1 positive are ABCs. At least in a large database, both from AIMS and from multi-institutional DLBCL patients, over 900 odd patients, or maybe 1,000 and more, we did not find CD10 and MUM1 able to distinguish between GCB and ABC to the point that we saw outcome differences at 5 years. So I would not go for IHC algorithms at all. If at all, we have to do the translocations that are available for MYC and BCL2. Again, BCL6 is not required anymore, because we know that those patients have a reasonably okay outcome. So that is where my things stand. So I would say, yeah, WHO 2016 for certain is one you should follow for treatment of most patients. Maybe 3-4% of the patients will be like the ones we discussed today, and so the WHO not only fifth edition, but the sixth edition is going to be likely to help us, which will take time to come, and that is going to have a lot of molecular work. So I think for all those of you are young and are going to pursue in lymphoid malignancies and myeloid malignancies for that matter, need to know WHO 2004 as your gospel truth. For me, I can get away with one edition less because now I'm going to super Anya it. So you all have to go through it.
Very true, ma'am. Basically, morphology and immunohistochemistry, you cannot do away with it. So WHO 4 for sure, but taking the newer things that have come in WHO 5, it has removed some diseases. So those, what Madam talked about, the various changes that have come about, has to be incorporated in your initial diagnosis. So that is there. That much we cannot do away with. So morphology with immunohistochemistry. So is very, very important. And like we don't have an entity like hairy cell leukemia variant. So you cannot label a disease as hairy cell leukemia variant currently. You will have to, for that, you really do not need the molecular, etc. But yes, for certain diseases, yes, we do need the cytogenetics or karyotyping or the molecular gene profile. So the initial part, that's what I'm trying to think. And Madam also said that for those who are junior, those who are learning, pick up your morphology and the immunohistochemistry well. That is going to give you further insight into what to do about a particular case. But without basic morphology and IHC also basic IHC, you cannot guide the clinician into any form of treatment. So that is very, very important. That's my way of looking at it. And classifications will keep coming, and we'll have to add on what is there and remove things that are redundant right now. So that way we'll have to evolve. So
Amit, if you want to hear a hilarious lecture, ask Dr. Anita Borges to do classification of classifications of subclassifications.
Yes.
That is, a really good, and she did that 25 years back.
Yes.
So to add with this, I think it will be excellent presentation from her side someday.
Yes, ma'am. Another question is again for you, ma'am. By Dr. Kannan. Do you really practice doing NGS in all the lymphomas now?
No. Not at
your management by any means.
No, we are till clonality and we stopped there. I'm seeing a lot of NGS reports coming from all the private centers when patients come to show us the reports over here. But I have not yet changed my practice. I am looking at the guidance trials very closely. And in a phase 2, I have burnt my hands many times in the last 35 years by jumping onto the bandwagon because a phase 2 trial has shown us excellent results. This has happened when we jumped onto the bandwagon of MACOG-B and so many other very intense chemotherapy regimens, only to realize that we increased the mortality, morbidity, and we actually may not have improved or sometimes even worsened the results. So I have burnt my fingers and now I wait for actual results before I actually put all this into. But I think for the younger people, again, like I said, one thing is the blood article is an eye opener. It is a very difficult article to understand. And honestly, I have taken just the highlights. But it is something you all must read to see how classifications are going to evolve over time. For us, it was easy if we followed our morphologists and the IHC. But for you, it will be important to understand how we kind of get molecular classifications to be validated. So that is one eye-opener of an article, which you all need to look into. Presently, my own recommendation is please maintain the dose intensity of the common drugs, because if you lose dose intensity, be sure your 5-year outcome will change by 20% and your complete response rates will not change. So I always tell my fellows also, I will be gone by reducing the doses, you will handle the relapses. So don't do that.
Yes, ma'am. Thank you, ma'am. Another question is from Dr. Raghavendra Rajeshwar regarding pediatric classical Hodgkin's lymphoma. If a patient has been partially responded to ABVD, what next step we should do? Should we go for NGS and then targeted therapy, or go for COP-based therapy, or an integrate with radiotherapy?
Okay, so the partial response is something which is interesting because whether it is on a PET scan or a CT scan, partial response is something that we need to define on a PET scan with duals. So if it is 1, 2, 3, you take it as metabolic response and you don't change the treatment after 2 cycles. And if it is 4 and 5, definitely you have to think. It is important to do a biopsy because in our setup, it's not unknown to have inflammations and infections increasing on therapy with chemotherapy. So always do a biopsy to prove whether there is disease or there is no disease over there before you make a change in treatment. The dictum was that if it is in the area of the original disease and it is duals 4 or 5, you can escalate to either BACOP or we used to find escalated BACOP extremely toxic in adults. So what we have been doing is if the biopsy shows disease, we give them something like bendamustine, brentuximab, because in Hodgkin's disease, we know that PDL1 expression is high and they respond very nicely to immune checkpoint inhibitors, as well as if you haven't used brentuximab upfront, it is a classically CD30 positive disease. So you can use either brentuximab, bendamustine, or brentuximab nivolumab to put this patient into remission. And once the patient is in remission, you can take a call. Most of us use 3 cycles. Large number of patients go into remission with the combination of these drugs. And then you can plan a high dose chemotherapy and an auto transplant. There are clinical trials being done outside, which I can only mention, but I have never taken the liberty to use them in patients, is to avoid auto transplants in these patients and continue with brentuximab and nivolumab combinations for a year or more. And if you prove, a certain number of complete metabolic responses on PET scans on the follow-up, they feel that at some point of time we will get away from high dose chemotherapy. These are trials running in Germany and the Nordic countries, and we have to wait for their results also. So I would be very careful. I would take a call on what metabolic activity is there. And if there is enough to suggest that this is a real partial response, I would like to see it on pathology, get away from inflammations, and then go ahead with a change in therapy because we are dealing with a child. So the more therapy we give, the worse is going to be the long-term toxicities. The other thing I will, if it is ABVD as your upfront treatment, you are fine. If you are using brentuximab with ABVD or nivolumab with ABVD upfront, remember your scan at the end of 2 cycles has no meaning because it may show even increase in the duals. It is actually inflammation of the checkpoint inhibitor and the anti-CD30. And so don't be in a hurry. And most of the trials, whether it is AAVD or NIVO-AVD, they have done the scans, but they have not changed the treatment after 2 cycles. They have completed 6 cycles, then done the end of treatment scan after 2 months or 3 months. And only then have they taken a decision about changing treatment. So it will also depend on what treatment you are using upfront because these drugs are notorious to show activity in the scan, and that is not necessarily progressive disease. And they have done the PET scans at 2 cycles in both these trials. I think for brentuximab AVD, that data is already out, and you can have a look at the data to show how many were inflammations and how many were really progressive diseases. The chance of progressive disease is very little on those therapies. And that's why we are seeing results like, stage 3 and 4, 90% complete responses and a long-term OS of 5 years, 6 years. It means that the inflammation is much higher than actually progression on these therapies.
Thank you, ma'am. Another question is regarding pediatric case of classical Hodgkin's lymphoma again. 11 years old male, stage 1A, early stage, favorable risk. Would you like to go for ABVD or OEPA?
I have no experience with OEPA, but I know my pediatricians are very fond of it because of, I believe, a much better side effect profile. But if it was not 11 years, let's say it was 21 years, and the ESR is low and it is small volume disease, I would just give 2 cycles of ABVD and very little involved field radiotherapy to the tune of 20 grays. And that is well proven that just that little therapy in an early stage favorable patient has absolutely good outcomes. So we can reduce therapy, we can use alternative, and it is only involved field RT. It is not as if you are in, it's not a local RT to that entire area. So single node nodal RT, 20 gray only, it's not even 30 gray, and just 2 cycles to debulk the disease, their outcomes are very good in the adults. I honestly don't like to comment on children because I think the pediatricians know it best.
Sure, ma'am. Yes, I finished all the questions from the audience. Let me check.
Thank you, Rina ma'am, for sharing all your wonderful experiences. And thank you, Basu sir, for adding up.
Yeah, we wouldn't have managed today if Dr. Basu wasn't here.
Not really. That's the beauty of hematopathology. It's always a combined effort.
Yeah,
That's why
yeah.
I enjoy. That's what.
I learned maximum from my labs in both the institutes.
Thank you. Any discussion want to ask any other question? Because I've finished all the questions from the audience.
Thank you, Amit. We've taken 2 hours.
Yeah, it's almost lunchtime for people.
Thank you so much, ma'am. In that case, I think all the questions are over. Fantastic discussion, fantastic and lovely, lovely, lovely lecture given by Dr. Rina ma'am. And very special thanks to Basu sir for helping us.
Thank you.
Thank you so
Thank
much.
you for calling me.
Thank you.
Thank you so much.
Thank you. We'll take care.